morning everyone. Today's our topic is cardiothoracic trauma. Myself, Dr. Apurva Shah, Assistant Professor working in Department of Cvts, UNMICRC Institute of Cardiology and Research Center. Coming to historical background, the earliest recorded reference to the Edwin Smith surgical papyrus, it was written around 3000 BCE. More recent historical background is assassination attempt on President Ronald Reagan by John Hickey on March 30 in 1981, in which the bullet struck in the president in his left chest and caused a non-fatal hemothorax. Initially, the treatment was open packing and local treatment with common ingredients like red meat, honey, lint, and they were the mainstay of the treatment. By 13th century, wound debridement and closure was advocated. Dividing the topic in emergency management, cardiac trauma, blunt and penetrating injuries, thoracic trauma, blunt and penetrating injuries. Coming to emergency management. First of all, we will do primary survey when the patient arrives. The goal is to identify immediate life-threatening injuries that could account for ventilatory or hemodynamic compromise, which if left uncorrected could cause death. Once the patient arrives in the emergency department, according to ATLS guideline, following the points in sequence are assessed. First, the airway is secured. Second, breathing is assessed by auscultation. Third, circulation is evaluated by palpation of peripheral pulses and simultaneous supported through the rapid establishment of large bore venous access and the initiation of fluid resuscitation. Fourth, neurological disabilities are assessed with GCS scoring. Fifth, the entire body is exposed to identify any significant deformities or penetrating injuries. Secondary survey. A quick head-to-toe physical examination is attempted to find any obvious constellation of symptoms indicating a life-threatening injury which needs urgent management. Example, evaluation of tracheal deviation away from the affected hemithorax along with the decreased breath sound, hyperresonance to percussion, distended neck veins is a clue to impending tension pneumothorax, which may have been missed in the primary survey. Or muff heart sounds, pulsus paradoxus, and jugular venous distension, which point towards the pericardial tamponade, known as Beck's triad. The image shown, it shows the cardiac box, which is marked, defined by midclavicular lines laterally, the sternal notch superiorly and the costal margins inferiorly. The investigation which we will do. First, doing the chest X-ray, there is a systemic review of the film should reveal suspected and unsuspected injuries and the presence of any foreign bodies. Fractures of the bony thorax including the ribs, clavicle, spine and scapula should be excluded. The lung field should be examined for pneumothorax, hemothorax or pulmonary contusions. Along the mediastinum, widening pneumomediastinum or shifting are highly suggestive of aortic transection, tracheobronchial or esophageal injuries or tension pneumothorax or hemothorax. The soft tissue may reveal subtle subcutaneous air or foreign bodies. Finally, the width of the cardiac silhouette may raise the suspicion of tamponade. The X-ray shows on the top images there is a rib fractures. In the second image there is hydropneumothorax. Second investigation will be ultrasound. Focused assessment of the sonographic evaluation of the trauma patient. Examination is done where 4 standard viewing pots are used to quickly assess the abnormal fluid collection. Right upper quadrant, left upper quadrant, pelvis and 4th the subxiphoid region, which is matter for cardiac traumas. In subxiphoid, most accurate as it is safe, expeditious, repeatable and effective even in the hands of surgeons from different specialties. The visceral or parietal pleura usually appears like ant marching, while lack of opposed pleural sliding indicates fluid or air. Comet tails are artifacts that indicates normal lung sliding on the B mode scan. The M mode usually show grainy artifacts that looks like a sandy beach with normal pleural opposition. When the sandy beach looks like a homogeneous barcode, there is pathognomic of pneumothorax, which is 99% specific and more sensitive than a plain radiograph. The E-FAST or extended FAST uses an extension of the right and left upper quadrant views to include the right and left hemithorax. Indication of angiographic studies for potential thoracic injuries are high-speed deceleration injuries, chest radiography finding, widened mediastinum, loss of aortic knob shadow, tracheal or esophageal deviation to the right, widening of the paraspinal strip or apical capping, downward displacement of the left mainstem bronchus, obliteration of the aortopulmonary window, fractured rib, sternum or scapula, multiple rib fractures of Lyell chest, massive hemothorax, in upper extremity hypertension, unexplained hypotension, pulse deficit or asymmetry, and when there is presence of systolic murmur. In CT scan and angiography, though more sensitive, is not essential for every patient with chest trauma and should not be performed in the severely hemodynamically unstable patient or in the presence of obvious life-threatening injury. Conventional angiography initially were choice of investigation in suspected cases of great vessel injury, but with the advancement in the technology, now CT angiography is the investigation of choice. The presence of mediastinal hematoma is often the first manifestation of aortic injury seen on the CTA. Trauma. First, blunt cardiac. There will be cardiac contusion, cardiac rupture, ventricular septal rupture, atrioventricular valve rupture, aortic cusp rupture. In blunt thorax, there will be chest wall injury, laryngeal injury, traumatic asphyxia, pulmonary contusion, tracheobronchial injury, great vessels injury. And when the trauma is penetrating, it can be stab wound, missile wound, and firearm injury. Cardiac trauma. Coming to the definition, cardiac trauma describes injury to the heart sustained by penetrating or blunt mechanism and encompasses a wide spectrum of prognosis from clinical silent to fatal. Mechanism of injury. If there is blunt trauma, it causes include most motor vehicle accidents and pedestrians struck by the vehicles, with there is a fall from significant height. Other mechanism including crush injuries and direct blows to the thorax from combat or sports. If there is penetrating trauma, it is often seen when a sharp, long-bladed instrument is violently driven into the mid portion of the thorax and penetrating the pericardium. A laceration of the heart or great vessels commonly results. The right ventricle alone is involved in 35% of the cases, the left ventricle in about 25% of the cases, and infrequently the right atrium alone is involved. Site of injury. Atrial and ventricular septal and free wall injuries. In blunt trauma, if the right atrium is involved, it gets torn at its confluence with the inferior vena cava, whereas the left atrium becomes torn at its confluence with the pulmonary vein. Theoretically, atrial injuries are more likely in late systole because they are near maximal dimension. Ventricular injuries do not appear to have a predictable location of the injury in blunt trauma. For those who survive the trip to a hospital, there is a broad spectrum of vague cardiac symptoms including chest pain, dyspnea, jugular venous distension, widened cardiac silhouette, hemothorax or pulmonary edema on chest radiograph. Treatment is usually surgical. Coronary injuries, which occurs in 2 to 3% of the lethal blunt cardiac trauma. The most injured coronaries are left anterior descending, which is because of its anterior position, and left main coronary arteries, which are 76%. The right coronary arteries are 12% chances of injuries and the left circumflex. Selective coronary angiography is the current gold standard for assessing coronary artery disease, dissection, aneurysm or rupture. Both cardiac catheterization and echocardiography can also assess myocardial regional wall motion abnormalities, which in conjunction with electrocardiogram changes may support the diagnosis of coronary artery injury. ECG finding in coronary artery injury include ST segment changes and ventricular arrhythmias. Laboratory investigation for cardiac enzymes may provide additional support for the diagnosis of coronary injury. Valvular injuries. The mitral valve is the most common valve involved in the blunt injury, followed by the aortic valve, tricuspid valve, and pulmonic valve. The higher frequency of mitral and aortic valvular injury may be a consequence of higher left-sided pressures. Clinical presentation include, but it is not limited to, acute dyspnea, pulmonary edema, widened pulse pressure, elevated jugular venous pressure, and a new murmur. Valvular injuries are best assessed with one or both transthoracic and transesophageal echocardiography. Patients with minor mitral valve injuries and mild to moderate mitral regurgitation may be medically managed with standard heart failure therapy and with the plans for eventual semi-elective surgical repair as needed. Those who present with severe mitral valve injuries and acute decompensated heart failure require an immediate operations. Surgical options include repair being attempted in some cases using well-established techniques like annuloplasty, leaflet resection, and implantation of neocordae to mitral valve replacement if needed. Aortic valve injuries may involve the annulus or cusp, and the avulsion of the non-coronary cusp from the annulus is the most common injury pattern. Most patients with severe injury present with acute heart failure following acute aortic regurgitation. Operative management typically entails aortic valve replacement in most patients, but repair has been successfully performed. Many tricuspid valve injuries may be treated conservatively as tricuspid regurgitation is relatively well tolerated. Operative management of tricuspid regurgitation includes valve repair in most cases, although valve replacement is necessary when the valve destruction is excessive. Injuries to the pulmonic valve are exceedingly rare, but management includes valve replacement. Coming to pericardial injuries. 36% of lethal cardiac injuries have pericardial tears. Approximately 50% of pericardial ruptures occur at the left pleuropericardium, followed by the diaphragmatic pericardium, right pleuropericardium, and superior pericardium. Cardiac herniation is a serious complication that may lead to obstruction of inflow and outflow vessels and thus severely impair cardiac output. Although minor pericardial injuries do not generally require repair, evidence of cardiac herniation is often an indication for urgent surgical repair. Closure of the pericardial defects can be achieved primarily or with augmentation using patch graft. Constrictive pericarditis is one of the major complications of the pericardial injury. Arrhythmias. Arrhythmias represent the most common complication of the cardiac injuries, up to 77% incidence. Sinus tachycardia is the most common ECG abnormality in the trauma patient, largely due to combination of pain, catecholamine surge, metabolic derangement, and hypovolemia. Other sinus tachycardia ECG abnormality present in 1 to 6% of the thoracic trauma patients with atrial fibrillation being the most common. Paroxysmal supraventricular tachycardia is a rarer atrial dysrhythmia that has been reported following blunt cardiac trauma. In general, treatment for atrial arrhythmias following cardiac trauma includes rate control with beta blockers for stable patients and cardioversion for unstable patients as per advanced cardiovascular life support algorithms. Complete atrioventricular nodal block is a rare complication and other than pacemaker insertion, treatment should be conservative. Commotio cordis. Commotio cordis refers to sudden cardiac death due to ventricular fibrillation triggered by relatively low energy blunt trauma to the thorax, which causes abnormalities in ventricular repolarization in the absence of structural damage to the heart. Approximately 75% of all commotio cordis is attributable to direct blows to the chest during spots, whereas 25% of the cases occur due to other mechanisms such as animal kicks. The cardiac arrest associated with commotio cordis appears more refractory to cardiopulmonary resuscitation and defibrillation compared to ischemic or hypoxic cardiac arrest even when initiated early. Blunt trauma chest wound, most common which includes rib fracture. It is most common blunt thoracic injury. Main symptoms include pain, exquisite point tenderness, and possibly crepitus. Chest radiography may fail to diagnose rib fracture, So the addition of CT to the trauma evaluation improves the sensitivity of the diagnosis of rib fracture. First, rib fracture has particular significance because great force required for it to occur. Likelihood of presence of intrathoracic visceral injury. The two most common sites of first rib fracture are the subclavian sulcus and in the neck for the first rib posteriorly. Intravenous favored for short-term pain relief include epidural analgesia, intercostal rib blocks, intrapleural instillation of anesthesia, and intravenous giving opiates and oral non-steroidal anti-inflammatory drugs. Continuous intercostal nerve blockade has been explored as an analgesic adjunct. Replating has been used increasingly for fixation of rib fracture and some general recommendation which include more than 3 rib fracture not requiring mechanical ventilation with severely displaced fractures or with mild or moderate displacement and impairment of pulmonary function despite optimal pain management. More than or equal to 5 rib flail segments requiring mechanical ventilation or severe displacement and symptomatic non-union. Perhaps the only contraindication would be sepsis or locally contaminated fluid. Patient must be reminded to practice adequate pulmonary toilet after discharge by using an incentive spirometer, deep breathing, coughing and ambulation. In addition to the chronic pain, other long-term sequelae includes chest wall deformities, persistent dyspnea and neurological deficit. A relatively uncommon but potential long-term complication of severe blunt chest wall trauma is a thoracic lung hernia. Flail chest. This injury usually results from the fracture of 3 or more ribs at two sides, either unilaterally or bilaterally. There is multiple contiguous rib fractures with multiple fractures of each rib. This promotes enough instability that the thoracic cage exhibits paradoxical motion locally as an evidence by thoracic wall collapse with inspiration. Endotracheal intubation is required in more than two-thirds of patients with flail chest and it is indicated for a respiratory rate greater than 40 breaths per minute or a partial pressure of oxygen of less than 60 mm Hg despite 60% face mask oxygen. Conservative therapy with emphasis on pain relief with thoracic epidural analgesia is a mainstay of therapy. However, the chest wall stabilization for the flail segments may be done. Other fractures may include sternum, clavicle and scapula. The management is similar to the rib fracture. Traumatic asphyxia. Traumatic asphyxia or Perthes syndrome is an uncommon clinical syndrome. Usually occurs after severe crushing or compression related injury to the chest preceded by deep inspiration. Symptoms and associated physical findings include subconjunctival hemorrhage, cervicofacial cyanosis resulting in a purple, blue neck and face discoloration, facial edema, vascular engorgement of the head, mucosal petechiae and multiple ecchymotic hemorrhages of the face, neck and upper chest. There will be cerebral hypoxia owing to hypoventilation, which is a life-threatening complication that can result in varying degree of cerebral dysfunction. There will be sore throat, hoarseness, dizziness, numbness and headache which are common. Pitting lower extremity edema, hemoptysis, hemotympanum, hematuria, rectal bleeding and transient visual loss can also be evident. Diagnosis is based on history and examination while management is largely conservative. Coming to pulmonary contusion. Pulmonary contusion is the most common injury in the blunt chest trauma. Classical symptoms include dyspnea, tachypnea, hemoptysis, cyanosis and hypotension. A physical examination can demonstrate inspiratory rales, decreased breath sounds on the affected side. CT scan is the study of choice. All patients with pulmonary contusion should be observed on supplementary oxygen in a monitored setting because of a tendency of the ventilatory status to deteriorate rapidly as 50 to 60% may develop ARDS. Often it can take up to 48 hours for contusion to blossom. CT findings are consistent with contusion are ground glass opacities that aren't bound by a particular segment. By standard ATLS protocol, patient with significant hypoxia with PaO2 less than 65 mmHg and saturation less than 90% despite oxygen supplementation should be intubated and undergo ventilation within 1 hour after injury. A conservative fluid management strategy should be undertaken. However, if large volumes of fluid are necessary for resuscitation of associated extrathoracic injuries, a pulmonary artery catheter should be placed. Management should include pulmonary toilet, diuretics, and conservative fluid management. Resolution of pulmonary contusion range from 3 to 14 days. Other surrounding structures which can be injured in thoracic trauma are larynx, tracheobronchial tree, esophagus, and depending on the injury, they are managed. Emergency department thoracotomy. ED thoracotomy plays a role in penetrating thoracic trauma. It allows a significant relief of cardiac tamponade, the ability to perform open cardiac massage, and control of ongoing intrathoracic hemorrhage. In addition, by applying a cross clamp to the thoracic aorta, one can limit intra-abdominal bleeding and improve cerebral and coronary perfusion in the setting of accentuating hemorrhage. The length of the time of pre-hospital CPR and is refractory metabolic acidosis are few determinants of whether to perform ED thoracotomy or not. Unsuccessful in an intubated patient for more than 10 minutes or more than 5 minutes in a non-intubated patients or in patient with pH less than 6.8 or severe base deficits. The accepted indication for ED thoracotomy are unresponsive hypotension, systolic blood pressure less than 60 mmHg, rapid exsanguination from indwelling chest tube less than 1500 ml, traumatic arrest with previous witnessed cardiac activity following penetrating thoracic injury, persistent hypotension with diagnosed cardiac tamponade and air embolism. Relative indication include traumatic arrest with previous witnessed cardiac activity following the blunt trauma, traumatic arrest with previously witnessed cardiac activity following penetrating chest injuries, pre-hospital cardiopulmonary resuscitation less than 10 minutes in intubated patient and 5 minutes in non-intubated patient. The contraindications for ED thoracotomy will be blunt thoracic injuries with no previously witnessed cardiac activity, multiple blunt trauma, and severe head injury. The important surgical steps for ED thoracotomy are: first, anterolateral thoracotomy in the left intercostal space, which can be extended to right side by dividing sternum horizontally with an oscillating saw, Lepschi knife, giggly saw, and even a good pair of trauma shears like bone cutters. The mammary vessels are divided. The pericardium is opened widely to allow easier evacuation of the clot, visualization of the heart, and the ability to perform more efficient open heart massage. Cross clamping the descending aorta requires opening the overlying parietal pleura, taking down the inferior pulmonary ligament, or retracting the inferior lobe in a superior fashion and then freeing the aorta from the esophagus bluntly via digital dissection. In penetrating trauma, EDT is more likely futile in the context of pulselessness greater than 15 minutes or asystole with no pericardial tamponade. In blunt trauma, EDT is likely futile if the patient has received more than 10 minutes of the pre-hospital CPR. Once stable, definitive management is done. Despite these extraordinary ED efforts on the part of the trauma team, overall survival rates of 1.8% to 27.5%. What is the role of the video assisted thoracic surgery in thoracic trauma? The indications are treatment for ongoing thoracic hemorrhage, treatment for retained hemothorax, treatment for persistent pneumothorax, diagnosis and treatment for diaphragmatic injuries, pericardial window for relief of cardiac tamponade, management of thoracic duct injuries, treatment of post-traumatic empyema, removal of foreign bodies. The relative contraindications will be coagulopathy, prior thoracotomy. The absolute contraindications are hemodynamic instability, suspected cardiac injury, suspected great vessel injury, inability to tolerate single lung ventilation, and inability to tolerate lateral decubitus position. If thoracic trauma is unrecognized, the complication will be pulmonary, pleural space, vascular, chest wall and mediastinum. In pulmonary, there will be atelectasis, acute respiratory distress syndrome, acute lung injury, pneumonia, infarction, lung abscess, atriovenous fistula, bronchial stenosis, tracheoesophageal fistula. If in pleural space, there will be empyema, bronchopleural fistula, organized hemothorax, chylothorax, fibrothorax, diaphragmatic hernias. In vascular, there will be thromboembolism, air embolism, pseudoaneurysm, great vessel fistula. In chest wall, there will be hernias, persistent pain, and in mediastinum, there will be mediastinitis and pericarditis. Thank you. Healing is a matter of time, but it is sometimes also a matter of opportunity.